Okay, if everybody could take their seats, we're going to get started. Okay, welcome back, everyone. Hopefully you got some fresh air. So before we get started, just a couple of housekeeping issues. So for the table mics, if you could speak into the microphone, that would be great. And also for the presenters as well, if you could speak into the microphone so that folks listening remotely can hear you. Okay, and as we did with theme 1, I'll give you a brief introduction, and then we'll have 4 5-minute talks followed by discussion. Okay, so for theme 2, this is improving processes for routine high-value clinical genomic testing. The question that we're asking is, what is needed to make genomic tests accurate, easy to use, and understandable? So for example, can we optimize tests for clinical setting? Can we develop a robust standardized sampling process for consenting, data interpretation, and return of results? And can we reduce the cost of consent for interpreting and returning genomic results? Oh, there we go. Okay, our speakers for this session are Amit Khera, Alicia Zhou, Michelle Clark, Mullai Murugan, and our moderator for this session is Tony Wynshaw-Boris. And I'll hand it over to the first speaker.
Thanks so much, Jyoti, and delighted to be here. And as you mentioned, my name is Amit Khera. I'm a doctor at Mass General Hospital and a physician scientist at the Broad Institute. Many of you who are familiar with Boston know that these institutions actually sit just across the river from one another. But, in really thinking about the last several years, there's been a relative paucity of instances where the genomic science that's developed at the Broad Institute has translated into changing the care of our patients at Mass General. And so, I think many others in this room really recognize that we're at an important tipping point where that information actually is ready in some cases to be translated over. So I'll start with thinking about the risk for heart attack, just because my background is as a cardiologist. And here you can see a clot actually rupturing in the vessel of somebody's heart. And there are actually a whole range of factors like blood cholesterol levels, what someone's diet is, whether they're a man or a woman. And over there on the right is actually genetic variants. Now, at present, genetic variants are not taken into consideration when you're predicting someone's risk for heart attack. But here, we and others have made some headway where, here's an example where the x-axis is actually the percentile of someone's polygenic score. Here's a measure that looks at many sites, common DNA variation, integrates that information into a single number, and that number is actually a bell-shaped distribution of inherited risk for heart attack. And on the y-axis is actually the prevalence of how many people had a heart attack by age 57 or so. And what you can see is that even from the age of birth, you could look at someone, and across the percentiles, there's about a 20-fold gradient in the risk for heart attack. Now, this is not to say that these scores will map to disease in a one-to-one fashion. A common example I like to use is that it's well known that actually watching the Super Bowl, a stressful Super Bowl game, will triple your risk for a heart attack that day. And so no DNA predictor can determine what the Super Bowl outcome is going to be 50 years in advance. Despite that, this and many other factors actually do enter in a probabilistic fashion in predicting your risk. So another thing that I'm working on, this is unpublished data, is actually thinking about integrated risk models. And so at the moment, for something like familial hypercholesterolemia, we might find, say, 0.5% of people who are considered high risk. These are monogenic risk mutation carriers. And so here I'm showing you that the y-axis is actually the chance that you have had a heart attack by age 75 in this case. On average, it might be 13% of non-carriers versus 41% of carriers. But it doesn't really stand to reason that you'd focus on just this one site of DNA variation and ignore the remaining 3 billion base pairs in our genome. So here's an effort that we put forth to really say, okay, well, how does where you stand in terms of your common variant background actually modify the penetrance of these important monogenic mutations? And so again, the current model would be to say everyone who's a carrier, maybe your risk is about 40%. But you can see that if you have a very good polygenic score, it may be closer to 20%. And a very high one, maybe it's 80%. So here's another example of an integrated, in this case only using DNA information, but an integrated risk model for an important disease. As Heidi mentioned, in her role as Chief Genomics Officer, she's overseeing genomics across the Institute. But one important pillar of that actually is the Preventive Genomics Clinic, which we're launching next month. And we made a few key decisions. One is to embed this into the primary care clinic at our hospital. And the second is really to focus on providing genetic testing within the confines of routine clinical practice. And we actually resisted the temptation to maybe market this as an executive health thing or something that's restricted to those who can afford, say, a $2,000 test. So the types of patients we're most excited to see is one is actually guide asymptomatic individuals who find out they have a monogenic mutation, for example, through our biobank. The second is actually discuss the genetic testing for people who are concerned because they have symptoms or family history. And the third is actually interpret the genome for people who are curious or concerned. So if you guys are in Boston for a business trip, please feel free to call me, and we're happy to offer that service as well. And really that last service, where if someone's very healthy, that would be considered a self-pay test. But many of the others we think will be considered routine clinical care. So these are just 3 examples of what I think are important opportunities. Our risk scores are getting better. Our clinics are starting to be laid out. And then I get to what are the important barriers, and what are the things that make everybody in the room groan. And we've heard a couple examples of that already. One is actually that there's an uncertain regulatory environment for genomic predictors that includes polygenic scores, but could include things like copy number variants, pharmacogenetics, and so forth. The second is actually the inability to integrate genetic testing, ordering, and resulting into our electronic health record. And the third is actually provider discomfort with the numerous testing options and some of the downstream applications that they may be liable for. So I think each of these 3 themes was touched on already today. But at least from my perspective, it's an example of something that really the NHGRI leadership could prove quite transformative in bringing stakeholders together in a way that no one group would actually push forward for. So let me stop there and look forward to questions as part of the discussion afterwards. Thank you.
Oh, the timer is being reset. Oh, yeah. All righty. So hi, everyone. My name is Alicia Zhou. I am the VP of Research and Scientific Affairs at Color, and I'm so excited to be here to discuss the different sort of thoughts around implementing genomics into routine clinical care. I think specifically for this section, we were asked to tackle this problem: improve processes for routine, high-value clinical genomic testing. And the way I think about that is, where we've come from to date has been making it more easy and accessible for individuals to get it in a one-to-one setting. But how do we think about making this more routine? I think Amit has made some great points about how we think about translating this into the clinic. Sort of looking back a bit, where am I pointing? Oh, here we go. I think these are 3 areas of barrier that we've already talked to about today that I think we have tackled in the last 5 to 10 years. So cost, access, and evidence generation. These are all themes that we've heard about earlier today already. I think we can all acknowledge that it can always be cheaper, but the cost has obviously dramatically decreased due to the access of NGS sequencing, all the new technologies that have come out that made it possible, and that cost continues to drop and hopefully will continue to drop. As far as access goes, I think a couple of different things play into access, right? Access can mean how well does a provider know that there are tests that exist that make that available to their patients. I think it can also mean how well do patients understand that they have choices that they can make, or that genetics is something that plays into their risk for disease. And I do think that we've made a lot of progress there as well. And honestly, we have to give a lot of credit to companies like 23andMe and Ancestry DNA who have brought the idea of genetics as something that the mainstream public can actually think about. They haven't yet really translated that into health-related things or clinical-related things, but they have brought genetics into the mainstream conversation rather than have it be this nerdy thing that I only see on NCIS. The last thing is evidence. I think evidence is something that we have spent as a field a long time generating, and really Terry gave a really great overview this morning about the way we've thought about the generation of evidence, even just from the beginning of generation of primary data to now understanding how that primary data translates to health-related diseases. And of course, there's a ton of different research projects that have been put towards this, and none of these are fully represented on this slide. But we have done a great job of starting to find standards. right? Now that we have ClinVar and ClinGen, we can actually start to standardize the way that we do our variant classifications. eMERGE is trying to tackle the way that we think about population genetics in a research context. We've talked about all of us already. Even the idea that the CDC Tier 1 genomics conditions exist as something that we can standardize around and say these are 10 genes, 3 conditions that are potentially ready for the population. This is, I think, progress that has been made. So then thinking about where we go next, I think there's really sort of 3 new areas I'd like us to consider to take us from the left side of the screen to the right side of the screen. Provider adoption for me is one of the big ones. I think we work with a lot of large health systems as well as self-insured employers actually to offer genetics as routine into their populations. And I think the difference between high adoption versus low adoption within the community actually very much is tied to provider adoption. And that means providers need to understand how they should be using this information. They should have comfort with the tests that they're going to be ordering, and they should feel like they are empowered to actually be able to deliver those results and be able to stand behind those results instead of feeling like maybe they don't have enough information to give it back to them. So bringing sort of the providers to the data is one, but then of course, I think the other part is bringing the data to the providers. I think EHR integration is incredibly important. We've already discussed this a little bit today, and Amit also brought it up in his talk. When you think about EHR integration, at the end of the day, if the information is not available at the fingertips of the provider in the system that they are used to using and they have in their office, then you will always be stuck in the early adopter phase, right? You're only going to have people who are willing to go out of their way, educate themselves, potentially pull up a different interface, pull up a different machine, maybe pull it up on their phone to be able to understand these results. If it's not in the EHR and it's not actually, there's not clinical decision support integrated into the EHR with actual alerts being fired based off of various germline mutations that are in there or even pharmacogenetic results that are in there to tell you, hey, you're about to prescribe a medication for your patient that they will not be a normal metabolizer for. It is a liability that provider has to take on, and if you don't make it easy for them and you don't make it something that they can just access at their fingertips, it will not become part of routine clinical care. And then the last piece is the same piece, which is evidence. But I think when we think about evidence, how can we think about real-world generation of evidence, where now it's not always about doing a full prospective clinical trial every time to prove the clinical utility of something, but how do we collect data as we go in the real world that actually can be used to serve the flywheel of clinical utility in a way that the payers will adopt and in a way that will actually help providers and patients adopt as well. Thank you.
There we go. Hi, everyone. I'm Michelle Clark. I am a statistical scientist at Rady Children's Institute for Genomic Medicine, where we do rapid clinical genome sequencing on critically ill children. And we are also conducting research really with the aim of making pediatric medicine, genomic medicine, the standard of care. So I wanted to start with a very brief story of one of our patients, because everything we do is motivated by our experiences in the hospital. So we had a 3-day-old little boy who presented to our hospital with uncontrollable seizures and severe generalized brain swelling. And the family history was significant for a older sibling who had died at 3 days old of SIDS. And so upon admission, rapid whole genome sequencing was immediately ordered. And within 34 hours, we found this child had compound heterozygous variants in MOX1. So a provisional diagnosis was made to the clinical care team at day of life 4, which is amazing. But sadly, the treatment for this disease is not FDA approved. And so an emergency investigational new drug application was considered. But due to the severity of the disease and the fact that it would take days to weeks to actually obtain the disease, the application was not submitted. And so what this case highlights is that even with such a rapid turnaround time, 34 hours to a provisional diagnosis. For this critically ill infant, it was not enough. And so what we see is a need for a comprehensive rapid precision medicine system. So I know we've mentioned newborn screening already today, but similar to newborn screening, we imagine the system as having three main components, which include onboarding, diagnosis, and precision medicine implementation. In terms of onboarding, this would include developing policies that define indications for rapid whole genome sequencing, as well as evaluating its efficacy for individual genetic diseases. It would also include rapid patient ascertainment, ordering, timely authorization, and consent. In terms of diagnosis, keeping that turnaround time as rapid as possible in routine clinical care is going to, we think, is going to need increasing amounts of automation. Additionally, I'm not pushing hard enough. We also feel there's a need for more studies on the analytic performance of genome sequencing. So here are some data from the ENSIGHT 2 study, which was a randomized controlled trial of rapid whole genome and whole exome sequencing. And we know that the analytic performance, the benchmarks are really well defined for SNPs and indels, but we still need work done for structural variants, and furthermore for regulatory variants, deep intronic splicing variants, and EQTLs, and on and on. And the last piece of the system is that precision medicine implementation. Right now, we feel that the reports that we give our clinicians are pretty meaningless. Why? Because it only reports whether a diagnosis was made, and if so, what that diagnosis was. But our real goal is changing outcomes. And if we're going to do that, these reports need treatment guidance and mechanisms to facilitate precision medicine. Of the 14,000 genetic diagnoses, only 725 have management guidelines. And as in my example, there were not all treatments are FDA approved. So we feel that if we're going to make big changes in mortality and morbidity for clinically ill infants, we need to make rapid whole genome sequencing a system, not just a test. Thank you.
Good afternoon. I am Mullai with the Baylor College of Medicine. I come from somewhat of an Better? Yeah. Okay. I am Mullai with the Baylor College of Medicine. I come from an informatics background. So today I am approaching this theme from somewhat of a health IT standpoint. I kind of did this as a gap analysis, starting with where we are first, where should we be, and how do we get there. So the current as-is state, this is probably familiar to all of you. Provider sees the patient, recommends a genetic test. The genetic test goes to a diagnostic lab. The diagnostic lab completes the test, sends the results back. The provider talks to the patient about a care plan. So when I look at this, the areas that are missing to me are information gaps, where, say for example, during initial data collection, we might not have family history, patient history, etc. But the thing that stands out to me really is this area here, where I understand this process is mostly manual at this point, where the request for a genetic test is entered manually in the EHR, and for the most part, this request is also again entered for a diagnostic lab. Then additionally, once the results are put together, it's mostly a PDF, and the PDF never automatically travels to the EHR. There is a person who's going in and uploading the PDF into the EHR. So looking at this, I see a big gap here, where there is no structured format for genetic data yet, a format that could be understood by the AHR. So not having a structured data and not having an interoperable process where the request from the AHR goes directly to the lab and where the results from the lab go directly back to the AHR limits clinical decision support substantially because the data is in the form of a PDF. You can't really parse and do much with a PDF. And then second, more importantly, is Mike, I think, mentioned health information exchange previously. So we all know about regional health exchanges and health exchanges like Epic's Care Everywhere, right? Where the information about a patient travels to each of the healthcare providers they see, as long as it is in a certain format. So PDFs apparently don't travel like that. So if we continue to use unstructured data like the PDF, and if we continue to not integrate with the EMR, then the patient's genetic test results do not really travel along with the patient. So this limits information exchange considerably. So, and then obviously, if the data is not in a structured format, we are also limiting analysis and research. So this to me is the as-is state. So where do we want to be? That is the to-be state. Same picture. Let's start with the easy one. So this is almost pre-test CDS. Maybe we could take the information we have in the EMR, add additional family history, etc., and go against something like the genetic testing repository and provide recommendations to the provider on what genetic test they could order for this patient. That's one. And getting to my favorite area here, in addition to a PDF, obviously we need PDFs. In addition to a PDF, we should work on creating a structured format for representing genetic data. If we did have that, we could obviously do CDS in a little bit more automated fashion, or at least in a semi-automated fashion. The next, more importantly, this data could be part of the patient's health record, and it could go with the patient, whichever healthcare provider they happen to see. So this, in a snapshot, could be the to-be state. How do we get there? So the goal in my mind is to make data, meaningful data, available when it is required. And how do we do that? We can start first by trying to put together genetic test results in a format that is understandable to the EHRs. We propose using national standards like HL7's FIRE or GA4GH. A full disclosure, this is something Larry Babb from the Broad and I are working on for the eMERGE project. Then one of the questions was, how can NSGRI help? Maybe by trying to support and drive these projects with groups like the HL7 Clinical Genomics. And not only that, just putting together the specification is not going to help. We need to battle test the specification with large scale projects. And I think Heidi mentioned this previously. We need to encourage EHR vendors like Epic and Cerner to adopt the specification. If they don't adopt it and we put it together, it's of no use anyhow. And then finally, these are all long-term goals. Oops, my time is up. We can have a short-term goal of just trying to include this data to the patient's basic record.
I don't think I need it, but I'll take it. Why not? Well, thank you to all the speakers for their interesting presentations. Now, if anybody in the audience has a pressing question, I'd be happy to take it now.
Click forward for that.
For comments. So I'm asking anybody in the audience for a pressing question. Oh, yes, please.
Hi, so my question is, for all of these proposals, is there a way to implement your ideas without exacerbating existing inequities?
Would you like to just go down? Inequities?
Actually, I mean, I'd say the one biggest theme that I heard was actually EHR integration, and there I think that all populations will stand to benefit, assuming that they had access to healthcare, and so wouldn't necessarily focus on that as a key barrier. I do wonder that, looking over this meeting, one notable absence actually given that theme is some of these EHR vendors. And so I think it may be something that's worth thinking about from even NHGRI leadership is should the EPIC folks or other folks actually be present for these conversations. And part of it, I think, is that, at least in my conversations with those types of people, is that if you get them excited enough about the science, there can be a will to try to move forward.
I mean, I think the 3 points that I talked about was exactly to try to address disparities in equity, right? Provider adoption is one of the big reasons why you might have inequity, is that there are more educated providers in certain areas, or they make the technology available to certain patients because they make a judgment call in the clinic about who should or shouldn't have access to certain tests. If you can make them more comfortable with the tests that they're going to be prescribing and who they should be giving it to, and making sure that they understand that, you're going to be able to help with the equity issue. There was a study that was conducted out of MD Anderson that looked at ovarian cancer patients who all should qualify for a BRCA test. And they looked at women who were Caucasian versus women who are African American and Hispanic in MD Anderson, and showed that among the women who had the same qualification, they all qualified for a BRCA test, that Hispanic and African American women were 38% less likely to be referred to the genetics clinic. Right, so that's a provider problem, right? The providers didn't recognize and understand that all of these patients should have been referred. So I think provider adoption is a huge piece, and I think part of that is EHR integration. If you are in a community clinic where you really have very limited amount of time to spend with your patients, and you have so many things that you want to hit with them, the idea that you have to go and pull up a different interface and educate yourself on a different machine, even you probably don't even have Wi-Fi in that clinic to be able to order a test, is just not accessible, right? But if it's integrated into the system that you see in front of you that you're already using for everything else, hopefully that makes it easier for you to actually do something with that.
Our vision with genomic sequencing in critically ill infants is that this is a technology that would be available to every child in the nation. The concept of sort of wrapping it together with newborn screening, I think, emphasizes the fact that we feel like every baby who is born should have access to this technology and be considered from the get-go whether or not they have an indication for rapid genome sequencing. Our hospital is very fortunate. We're in a very diverse area, and this month we just wrapped up a project with Medi-Cal. So they were doing a pilot program called Baby Bear, Project Baby Bear, where they funded 100 genomes to be sequenced at our hospital and a couple other sites, so that they can in the future possibly cover this expense. So our goal, everything we do, is to make this available to everyone.
This has been something that's been on my mind lately. We are working on a genomic spec, which is a long-term goal, but you asked about short-term goals, right? I realized that for the most part, physicians don't even know that a genetic test has been ordered or what the results are. So maybe a simple short-term goal would be to take at least the core result and add it to something like the patient's problem list. This is something we are working on for eMERGE. So it doesn't have to be an extensive model. It doesn't have to have major support from the EHR vendors or anything. But if we could just take the basic result and add it to the patient's record, maybe the patient's ADT or something, then this is information that will travel with the patient wherever they go, which means any other healthcare provider who's seeing this patient will be able to see this information. I have to give credit to Casey. This is a use case we are thinking about for eMERGE.
Well, while we're waiting for another question, and so in some of the cases, for instance, with yours, with the Rady case, we're talking about individual patients, but for others with high risk for, or potentially high risk for cardiovascular disease, a population may be the target. So what are the challenges for bringing routine high-value clinical genomics to individuals and populations? And do we need to consider the differences between those different groups? Why don't we start the other end?
Starting this way?
Yes, we'll start there.
Okay. I am mostly with health IT, so, but this time maybe I will wear the hat of maybe a patient. So a big thing is there is not enough information, I feel, about the field of genetics itself and how it could impact your healthcare. So whoever I talk to when I try to explain what I do, I say, we do this and we find this. But then the question is, okay, then what does it mean to me? How does it change care for me? And it could, a lot of times, there are no easy answers for this. It's a finding, it's a diagnosis, but then where does it go from there? So creating, at least from my standpoint as a non-clinician, non-geneticist, creating awareness of this, making this more commonplace, like tests people understand, right? Like a blood test, you know what you're doing, you know what the results mean. That I think might be helpful.
Yeah, we've been having a lot of discussions on the difference between indication-based testing and preemptive testing. Like with my example with this infant, he had an older sibling who died at 3 days old of SIDS. And so this little boy would have greatly benefited knowing that information from screening early on. And so I think that there's got to be this balance between recognizing that if we screen everybody and we're able to save lives, that would benefit a lot of people. But there are so many intricacies to that. And right now, really focusing on indication-based testing seems to be the best way to go for us.
I mean, I think some of the nuance in your question is sort of the difference between clinical utility and personal utility, right? And I think at the end of the day, when you think about that, then it's all about the usability of the data for the user. For an individual, if you have the results of genetic tests, you want to be able to look at it and not see alphabet soup. You want to be able to look at it and understand, what am I supposed to do next, right? When is the next time I should go see my doctor? Do I need more screening? Should I be taking a different drug? Those are the things you want to be able to understand, and being able to deliver that in a concise way to a person, what maybe even on their mobile device, would be a really great way to make that possible for an individual. From a population standpoint, I actually think it's the same thing, but for providers, right? A provider also doesn't want to see alphabet soup. A provider also wants to know, what am I supposed to tell to my patient right now? Do I need to change their drug? Do I need them to come in more frequently for screening for some disease? And similarly, making it so that the provider can deliver that information back to their patient in a way that is fast and easy for them is the way you're going to be able to get population adoption of this as well. So I think it's both. I do think real-world evidence is really important. If we have to wait every time to do a full prospective clinical trial for everything, it will take a very long time for us, for polygenic risk scores to get adopted into the clinic. But if we can think about how we can embed those studies into existing, into MyCode, into eMERGE, which is happening, into all of us, which hopefully will happen, then all of a sudden you can accelerate the flywheel of research without having to do a brand new study for everything.
I was just going to follow on some of the comments that you'd made, everyone on the panel, about the preemptive versus indication-based testing and how you think we can learn about sort of the high-value moments over time. Because I think, and this is something at NSGC we've been thinking a lot about, is what are the highest value time periods to deliver services to people? When do they need it most? And I think the problem with indication-based testing, especially when you're talking about like in a NICU setting, there's a lot going on and there's a really stressful time. And for some people, having more genomic information may help, but for other people, that's a really difficult time to engage with something that is sort of cognitively really complex. And then on the preemptive side, you have almost the opposite problem, a problem of salience. Why is this important to me? Why is this important to me now? Why should I care about it? Especially if it's genetic information that doesn't jive with their life experience, but there may be times when it does. And so how do we find and capture that, both in the healthcare system, but also maybe outside, to bring folks into the healthcare system when they may be more likely to engage?
You want to take this? You want me to start, huh? Well, I think that this is obviously a key question, and perhaps the way to think about it is what, at different time points, what might, high-value testing involve. Certainly for the critically ill neonate in the NICU, it's going to be exome sequencing and try to find a diagnosis for the infant. But for others, a woman or male with cancer, with a cancer mutation in their tumor, reflex to germline testing. We talked about that kind of analysis before. Pharmacogenomics might be a different thing for drug indications. Integrating with the EHR would be a great way to do some of those more selected tests. But, EHR, we've already talked about some of the problems that we have. But I think it's good to identify at different stages and in different populations what kind of high-value testing we might get, or we might want to consider.
Yeah, I think we have a nice opportunity within genomic medicine to deliver on some relatively low-hanging fruit, specifically with indication-based testing, where I think there can be a consensus that it could be useful. The CDC Tier 1 diseases is one reasonable place to start. I think newborn testing, maybe another. And I think those are examples where I think, sequencing those peoples is not a large segment of the population, and we can demonstrate some early wins. I think the population screening, I think that really the onus is on the research community to prove that it's useful. I think we have some early evidence from places like Mark and Mike who did work at Geisinger, Mayo Partners. We've all been doing stuff with our biobanks, but I wouldn't say that the folks. Us as a community, we've convinced the world that genomic testing for everyone or at the time of birth is useful. And so I think that's something we have to take upon ourselves to say, how do we convince the world over the next 10 years that it could be useful?
Yeah, I think Mark made a great point earlier in the day, which is that your germline genetics is a static data set that you have from the day you're born until the day you die. And it's about how do we make that useful to you in the moment. And it's something that we actually think quite a lot about. And I think about Mary Claire King has this great sort of point of view when you ask her, what do you tell a 19-year-old who has a BRCA1 mutation? And she said, you tell them to wear a seatbelt. Where that information is going to be most useful really depends on all the other contexts of life that surround where you are, right? That germline genetic risk is there. There are other clinical risk factors that are going to present over time. There's familial risk that you probably also have that's not captured yet because we don't understand it yet. But it really is, how do we make this static data set something that's dynamic for you to be able to interact with? Another great example of that is pharmacogenomic testing, where right now I can know all of the possible set of drugs that you may have a poor metabolizer status for, but until you're actually prescribed that drug, it really doesn't matter. And so how do I make sure that you get the most salient information at the moment that you need it? That is the job, sort of, I think, of the EHR to have best practice alerts that actually fire, right? But also, is there a way for us as a community to think about how to engage the patient and participant population so that they also, instead of waiting to be told that something's going wrong, that they understand what that data means to them and knows when they should be thinking about, taking their next actions.
Another question that comes up when dealing with children and preemptive screening is who and when do we give the information to? So is it the parents at the time of the screening? Or is it when the child turns 18 and is an adult? It's a lot of information. You said like alphabet soup. And when is the right time when we're thinking about these kids who are not yet adults? When is the right time to give that information, and how do we provide it?
So following up a little on that, when I had my child, I was in no condition to listen to, genetic testing or newborn screening. It was like whatever. So maybe a little later than that, maybe when they're around 5 or so, all children are taken to pediatricians for like well child appointments or something. So I feel pediatricians might be a good target to educate them, to let them know these are all possible genetic tests. And if you do this test for your child, that information becomes part of the child's record and can help with care going forward, PGX or even any inherited conditions. Maybe that might be a good place to start this preemptively as opposed to based on indication. Then another thing, I don't know how feasible this is, this employee wellness test, right, at organizations are gaining a lot of traction. I've done that with Baylor, and the results come back to me in a format which is so easily understandable with thresholds, etc. So maybe that's another area to tackle. What are simple indicators that could be part of a wellness test to gain more popularity, more understanding with people about tests like this?
I think part of the problem is in the messaging that we're sending. You know, genetics is this esoteric service that gets called in last minute. And I would use the analogy of palliative care. There's been sort of a transition in how palliative care has been viewed in the NICU and in other settings. It used to be you call them in the last minute and they're part of, you know, an afterthought or a late stage interaction. Instead of what they are now talking about is bringing them in as part of the team from the setting expectations from the start, so that this is just like the cardiologist, the neonatologist, the pulmonary person, having them there from the start, and then where their role evolves kind of depends on the complexity and severity of the findings, relevant or not.
Any comments from any of you? Well, a very good point, but of course then that begs the question of where these folks are going to come from. We need a genetics workforce task force. Yes, Mike.
So this one's specifically for Amit. So the polygenic risk scores are going to identify two potential groups that might benefit for common disease in adults. There'll be the people that should have known they were at risk anyway and should have discussed it with their doctor, somebody with relatively high cholesterol or multiple Framingham heart disease risks. And then it's going to identify a group of people that don't have any of those risks and just have your polygenic risk score. So how much prospective clinical outcomes data do we need before we start applying the polygenic risk scores? Because as you know, everybody that can run an array wants to start doing polygenic risk scores for their neighborhood. So, so what's your advice?
Well, sorry, do you want to say your opinion?
Here you go. He's asking
you first.
Yeah. Well, I think one aspect of the question was specifically around what prospective information do we need. I mean, there I would say that the evidence is quite clear for a whole range of groups, like for a whole range of diseases, that these individuals are at substantially increased risk of developing disease. And so in terms of the questions of what level of evidence do we need that translates into like risk reduction, I think that's where I think, you know, it depends on your perspective. I think there's good observational evidence that, for example, a healthy lifestyle can actually normalize your risk even if you're at high genetic susceptibility. You know, going back to, we've gone back now to several clinical trials, some published, some not, where we basically, people didn't know what their polygenic score was at the time they enrolled in that clinical trial. But we can then go back and show that maybe these high polygenic score people were actually the most likely to benefit, for example, from statin medications and potentially others. So for me, I think, you know, if I'm seeing the patient, I do think that I can put that evidence base in the context of what might be realistically expected. But I don't necessarily see that for every disease we'll have a randomized trial that's, you know, for example, 10 years follow-up where we prove we're reducing heart attacks.
If I could just very slightly reframe Mike's question, what is the strategic opportunity for NHGRI in research on this question?
Yeah.
I'll say.
Well, I would say that I would actually focus on the three that I mentioned on the slide. The first is actually it's uncertain what the regulatory environment is for making polygenic scores a clinical result. And so as part of various research studies we've done, there's some people who actually have had a heart attack or have a very strong family history. They, as a research result, actually found out they have a very high polygenic score. In some sense, you know, getting an explanation for why this is run in their families. Similarly, there's some severely obese patients who actually, in response to a paper that we came out with, have actually understood now as a research result that they're one of the reasons they may have struggled with this, for their life is that they may have had a high genetic predisposition that made them, for example, 10 times more likely to be severely obese than somebody who is at average risk. And so I think the regulatory environment to transition that disclosure, which I think can be useful for a number of people, is the regulatory environment I think will be important. I think that's number one for NHGRI. I think number two is that as many have said, when the test is done, even if it was a clinical result, how can we get it into the EHR? And then the third, I think, has to do with with this provider education piece. So, Heidi mentioned an e-consult program we started. It's now actually any of the partners hospitals can ask a team. There are about 7 of us. I think my $50 actually got taken away this morning while I wasn't here. But just joking. But either way, anyway, so there's a small fee associated with it. But there's about a team of 7 of us who actually put our heads together and try to answer that for any provider, at least in our health system. But I think, even talking to Dr. Green this morning, I think there's an important need for us in this room to actually put together a set of educational resources for the world, essentially, to try to overcome this provider education gap.
I think a couple of things. One, I think not every polygenic risk score is created equal. And so I think when we think about talking about the clinical utility of polygenic risk, I think we have to think about which disease areas we're talking about and which scores. It's the same thing as trying to say all of clinical genetics were the same, right? Testing for the clinical utility of BRCA testing is very different than testing for the clinical utility of CHEK2 or ATM testing for breast cancer. And so I do think of all the scores that are out there, the one that's most ready for prime time in terms of clinical utility is the CAD score, Amit's CAD score. I think it has the most amount of evidence already in retrospective studies across UK Biobank and other large cohorts that show that it does do a good job of stratifying individuals into different risk. The question then is, what is the utility of that? And I think a couple of things. One, we should be comparing to the utility of this score against what is currently used in clinic to actually stratify patients into risk. Instead of saying, can I tell your absolute risks of coronary artery disease in your lifetime, which is a very high bar to try to hold ourselves to, we should be saying, can this score do a better job than LDL cholesterol, than Framingham, or other clinical risk factors that are being taken into account by a clinician right now in identifying individuals who are at higher risk. I think, two, the other piece is that where we are with polygenic risk right now is I think it is useful right now is in resource allocation in a health system. So if you're a health system and you're about to have a high intervention clinic where you're going to go and do targeted intervention on a set of patients, give them lifestyle coaches and, call them every day and make sure that they're doing exercise or taking their statin or whatever those things, that's an expensive program for your health system to pay for. I think a polygenic risk score was a great way for you to determine which patients should qualify for that. And it's less about being able to tell you what is your absolute risks. I think that is something that we're still not sure about, especially for non-Caucasian populations. But it is about saying, if I know that I can make this program available to 100 patients, how do I best target the 100 patients for that? And so I think thinking about clinical utility in a different way and thinking about how to do a non-inferiority study against current standard of care practice instead of trying to define lifetime risk would be an interesting way to think about that, instead of always thinking about how to do it in the most sort of mathematical way.
But somebody has to do the hard work of deciding what to do with those patients, right? So if you go to MGH, you'll get one expert's advice. If you go to the Cleveland Clinic, you'll get a different expert's advice. Do I go on a high-dose statin? Do I go on a low-dose statin? What do I do, doc? So that all has to be worked out, and I don't know the best way to get there, but we need to get there.
Another way of thinking about it maybe is, can one add polygenic risk score, its genes, with all the other things that we also work together? So one could look at adding that in with all of the other possible ways of measuring risk for diabetes. One can imagine polygenic risk scores could be part of that. And maybe the way to consider framing it for what could the NHGRI do for us, maybe is to consider figuring some way to put a grant proposal out to see how to evaluate polygenic risk scores in the context of other risks or on its own, whatever would be useful in that sense. Yes,
And the last point there, the 19-year-old with BRCA needs to avoid unnecessary CAT scans, so she shouldn't just wear a sequin.
Yeah, I just wanted to follow up on this last comment about the PRSs and other risk determinants. So one of the areas that it seems obvious is to compare PRSs to family history and to determine whether family history is equal to or inferior to PRSs, or can actually be included in the risk equation for, or in the algorithm for risk. Because I don't think we really know that, and obviously family history is a lot less expensive to deliver to a healthcare delivery system than a PRS is today, and it's accepted clinically.
And I think, again, it's the idea of what is it going to do for the individual versus what it's going to do as part of a healthcare system, and perhaps evaluating under those different scenarios would be a good way to do it as well.
I just quickly addressing the family history question, which is a very important one, and I would say that family history in general is actually a proxy for either shared DNA or shared environment, and so I do at least even from a conceptual standpoint, I do like the ability to look directly at someone's DNA to figure out what's the genetic component. In a number of studies, we and others have looked, and actually there's very little overlap between self-reported family history and polygenic scores. For example, if you look at people with high polygenic scores versus normal, you might see a difference of family history of, let's say, 40% versus 34%. So the family history is certainly enriched, as you might predict, but it certainly does not track with marked difference in the polygenic score. Similarly, I think you mentioned that you could add both of them into the model, and there I think they actually minimally attenuate each other's risk score. I mean, they both have independent risk information. I think largely because family history, again, is not necessarily attenuated by DNA-based measures because a lot of it's shared environment, and polygenic scores, as I mentioned, don't really track that well with family history. But one of the comments from the Rady experience, I think, really resonated with me, which is, a lot of looking back over the 2011 genomic medicine framework, a lot of it was getting to the point where we can predict risk for a range of important diseases. And in some ways that was almost phrased as like an important goal. I mean, it was an important goal, but really the way you phrased it, I think, is much better, which is these genomic diagnoses, whether it's whole genome sequencing in the NICU or a polygenic scores, is actually not the end, but actually the starting point. And the fact that we can do this now is, I think, scientifically remarkable, to be able to look at a newborn and diagnose them with a rare epileptiform disease or a high polygenic risk for coronary disease. Like scientifically, I think that's just really striking to me. But for us, I think that's really a starting point of now we say, what do we do with it? How do we convince the world that it's useful, and how can we move it forward?
Is race factored into the polygenic risk score calculation?
So the question was about whether or not race and ethnicity can or should be factored into the polygenic score calculation, and certainly it's a very important aspect. And so, we and others have shown that it's very important to take into account someone's genetic background in terms of calibrating their score appropriately. So, like my score be interpreted compared to a distribution of other South Asians, for example, and that I think is relatively straightforward computationally. There's a second important equity issue, which is that regardless of your race, as Alicia mentioned, your polygenic score will help you do better than in predicting your risk than you would with the standard of clinical care currently. So everyone does better, but at the moment the incremental improvement is the most actually in folks of European ancestry, and so that's something that we are working very hard on, both in terms of better algorithms and studying more diverse ancestries, and I mean, partly just within our group, but actually nationally and internationally, including Millions Veterans Program, the All of Us Precision Medicine Initiative, which is really taking that head on. So I think those gradients are likely to continue to improve over time.
One of the issues I think that we sort of overlook in this genomics community is that even for coronary disease, the genetic contribution to risk is less than 50%. And so even if you have a perfect polygenic risk score, there's going to be a lot of noise around that. And then the question is, what is the added value? There's no question that you can find people, if you look at a large data set, you can find people who have had early heart attacks and their polygenic risk scores are high. Fine. But what does it add to standard predictors like Framingham, which, by the way, have never been subject to a randomized clinical trial, my friend Dr. Ginsberg points out to me. So I think the enthusiasm is there because we finally have a way of understanding the complex genetic architecture of some of these complex diseases, but where they fit into practice, I think, is going to be a long slog, and I'm worried that we, as a community, adopt these kind of predictors without any evidence of where they're most useful and without any evidence of what value they add. End of rant.
So to answer, I was actually going to comment on Mike's, but since Dan raised that comment, I think I would refer you to the randomized clinical trial we did as part of eMERGE, where we randomized 200 intermediate risk patients to getting a genetic risk score versus just a conventional risk score. And so, Mike, in that scenario, we were able to give that information to patients and providers, and we used a shared decision-making about statins. And we saw that giving a genetic risk score in the clinical setting was actionable. Patients and providers made decisions about statins, dosage or initiation. And in fact, that eventually led to a reduction in LDL levels 6 months after the disclosure. So I think many of the concepts that were discussed, I would refer you to that study. And to Dan's point, I think CAD offers a really nice framework because you bin patients into intermediate, low, and high risk. And I think the question always for the provider is what to do with the intermediate risk. And that's where restratification with the genetic risk score can be quite substantial and helpful in decision making.
I agree with what you all said, that it is really important to give busy clinicians one-stop shopping and try to keep them in the EHR and all the information in the EHR. I think as those of you who are developing systems to get information in there, I think UI and UX testing is really important, both from a provider perspective and a patient perspective, because I think there were some assumptions made about EHRs as an equalizer around health disparities, and that's not necessarily the case. There are real issues about linguistic, what languages it's in, how many minutes people have on their phone, other kinds of things, also things about providers. So beyond UI and UX, I think it would be important to consider having patients and providers at the table as we're starting to develop these systems so we don't go too far off track from what they need before we finalize it.
The thing I keep thinking of is that we can make sure that the tests are great and we can make sure that the EMR system is great, but what we're really talking about is behavior change. We're talking about provider and patient behavior change. So in terms of a grand challenge for NHGRI to be putting out RFAs that are studying how we get providers to change their behavior and how we get patients to change their behavior and which interventions, whether it's some form of in-person genetic counseling or some form of scaled online system that provides something, or it's alerts, or it's a subscription, or it's the system in the EMR, those are the kinds of, we need to be looking at interventions that are targeted towards those outcomes, and we can think of, EMR integration or polygenic risk scores as interventions.
And so I was just going to throw out a couple of cautions. One is the concept that the EHR is our savior is something that I think will lead us down a dead end. Yes, it is software, it is potentially malleable, but it is a beast, and that is a sanitized word. With any of these plans that rely on the EHR being able to change so it does something that you want it to do, you can go down that path, but you darn well better have a backup plan that works almost as well as you envision the EHR plan to work. The second caution is about the polygenic risk scores. As an older geneticist, when I came up through genetics, we were mapping genes and families using LOD scores. So we were using statistics. Those statistics didn't rely on the ethnic or the ancestral background of the individuals. Once we found a positive LOD score, somebody did some research to figure out what the biology was behind it. So I still have concern about using polygenic risk scores because it's simply a statistical observation. And if we're going to be treating patients differently on the basis of that, I still have some discomfort with the absence of any biology behind it. So those are my two cautions.
So in listening to the conversation so far today, I think one of my observations is that we are all observing the brokenness of the US medical system, right? And the question is really for NHGRI, how can we use genomic medicine as a pathway out? And I'm sensing a tension in the room between a incrementalism argument and a radicalism argument. And I feel like we're, as clinicians, going more down the incrementalist pathway. And I just wanted to bring that to our attention and start for us, maybe we could start to think a little bit more about what are some of the potentially more radical solutions that we could introduce, thinking about genomic medicine as a vehicle for addressing or as finding a way out of some of the brokenness of the system that we find ourselves working.
So let's hear some of those radical solutions. Last year's is not working.
Right. Make no small plans, for they do not engage the spirit of man, or something to that. Spirit of all should be. If I can continue, okay. I took a shot. What can I say?
So you had someone up here, right?
So I had a comment about implementation around the different types of genetic results, and I've been reading more about agile implementation, where for health behavior change you can do studies within a study where you can see what works, what doesn't work, and make changes based upon that very quickly in an agile way. And so I feel like if there were ways to do this within the EHR, we would benefit from being able to make changes quickly. And it is possible to some extent, because most EHRs have a testing EHR. You can monitor things in the background, but the process of making changes to what currently exists is a very long process, and so ways to think about broadly how we can do that. So just a comment.
I also wanted to make a comment about sort of what is the direction that NHGRI can take this in. I think all of the things that have been spoken about, at the end of the day, if the studies that are funded are actually the ones that are tracking outcomes, then all of these pieces, whether testing whether EHR is the right way to go or not, testing what kind of language we use and how, what are the interventions and how and when, these all things, the common denominator there is there need to be improved patient outcomes, and then comprehension, right? Provider and patient comprehension. If these are the endpoints that you're assessing in your study, then it necessitates the study designer to actually take all of those things into consideration, and hopefully gets you closer to solving some of these problems.
Yeah, I wanted to pull together a couple of threads here and bring it back to the question, what can NHGRI do? As opposed to Bob, I'm not a nihilist about the EHR. For those of us that have actually done it, we know it works. The problem with the EHR is that we can get it to work at our place, but we can't give it to you and have it work at your place. So the issue is not that it can't be done, it's that it's done on one-offs and it's not generalizable. So that is a significant issue. I'm also, I would not want to put NHGRI in the position of using genomics to fix the healthcare system. I think that is, maybe that was an oversimplification what Megan was providing, but the reality is
just to clarify.
I'm making a point. So,
But to clarify my point, so it's not misinterpreted, I wanted to point out the ways in which we could use genomic medicine as a vehicle. So when we think about equity, for example, and inclusion of populations and health disparity, how could we use genomic medicine so that we're not just recapitulating all of the problems that exist in our current medical system, right? And this is a theme that's been coming up. So a very different point than yours, Mark, sorry.
Yeah, well, but it's relevant in the sense that innovation, really to be successful, requires slack resources and an unregulated environment, of which healthcare has neither. So we do have to operate within that reality. The third point that was made that I think is very important is the idea that we've done less work than we probably should have in terms of end user evaluation, particularly patient end user evaluation. And having done a lot of this and recognize that patients are going to have more and more ownership of what they're doing with their data, I think this is a really rich area of exploration for NHGRI, which is how can we use patients as the recipient, because the patient is the only actor in the healthcare system that's consistent. If we can somehow get that information to the patient in a way that they can use it and bring it along with them to the healthcare system as they do their encounters in a usable way, that would be an agent of change that would clearly be radical and would, make the patient the agent of change, which has had some success in the past. It's not a trivial problem, but I think it's a really interesting way to think about a research agenda.
We have a brief one here, and I think we have to wrap.
So I am in Bob's camp on not complete confidence in EPIC solving our problems here. One thing, we have a grant that is trying to create an innovation platform on top of EPIC, because I think one of the big challenges is the legal and ownership framework of EPIC, making it incredibly difficult to innovate in that system. And so the idea here was to create a separated layer so that you could allow physicians, informaticists to innovate and build apps without having to deal and interact with EPIC. If that works, like a goal for NHGRI would be really to fund all of that innovation in apps, the same way we have new apps on our iPhones every day that do all sorts of cool stuff, and anybody can create an app. And so thinking about, if we could separate ourselves from the incredible difficulty in working with current EHR systems and be able to allow this innovation and fund innovation to deliver information to physicians to make real-time decisions, I think we could disseminate huge rapid progress in medicine and clinical decision support. But we have to have that on a framework that we can allow innovation. And so I think that's one way to think about it, is not, as I said before, can we get EPIC to prioritize genetics, but actually can we separate ourselves from EPIC and Cerner and the others?
Well, yep, thanks everybody, and please thank all the speakers today too as well. Who gets this? Are you next?
I think I'll take the clicker. Thank you.